All right, let's go ahead and get started. My name is Noelle Young. I'm a neonatologist from Duke University in the US. And on behalf of the Tiny Baby Collaborative, it's my pleasure to welcome you to this webinar focused on skincare for infants born at less than 24 weeks gestation. Following today's session, please save the date for our next webinar, which will be held on September 19th. That session will focus on bacterial and fungal infections in infants born at less than or equal to 23 weeks gestation. And then on November 12th, we're planning a webinar focused on obstetric management. Just a few housekeeping notes before we get started. The webinar today is being recorded and the video will be posted on our website, tinybabycollaborative.org, for later viewing. As always, we welcome multidisciplinary attendance at these webinars, including parents and families. If you have questions that come up during today's session, please use the Q&A button in Zoom to post your questions. And our speakers and moderators will do their best to address these, as well as any questions that were submitted ahead of time in the registration forms during the Q&A portion of the webinar. Registered for the webinar today, we're pleased to have a multidisciplinary group, including around 40% attending neonatologists, 32% nurses, 11% nurse practitioners and physician assistants, as well as trainees, researchers, parents, and others representing more than 40 countries. So we asked a few survey questions in the registration form, and I'll take just a moment to share the responses. So first, we asked the incubator humidity setting that is used in your hospital for infants born at less than 24 weeks gestation on the first postnatal day. And you can see here that around half of you responded that the initial humidity setting is between 80 to 89%, followed by 70 to 79% for 25% of respondents, and 90% or greater with 19% of responses. And next, we asked whether you place EKG leads on the skin in the first postnatal week for these infants. And you can see that 73% responded yes, and 27% no. And then we asked about antiseptic use for umbilical catheter placement. And you can see that just over half of respondents reported using a povidone iodine solution or betadine, followed by 28% of responses were chlorhexidine, and the remaining 20% used other solutions or alcohol. For peripheral central line placement, there was more use of chlorhexidine, so around 40% of responses using povidone iodine and around 40% using chlorhexidine. So for today's agenda, our first speaker will be Dr. Marty Visscher. Dr. Visscher is the director of the Skin Sciences Program at Cincinnati Children's Hospital Medical Center. She is a chemist and a biomedical researcher, and her areas of research focus include neonatal skin development, sorry about that, and repair. Let's go ahead and stop sharing. She will talk today about unique features of skin in tiny babies and skin maturation. Following her talk, we will hear from Carolyn Lund, who is an associate clinical professor in the School of Nursing at the University of California in San Francisco. She was the neonatal clinical specialist in the NICU and ECMO coordinator for UCSF Benioff Children's Hospital, Oakland, for over 40 years. And she was the science team leader for the development of neonatal skin care guidelines for the Association of Women's Health Obstetrics and Neonatal Nurses and the National Association of Neonatal Nurses. After their two presentations, we'll have time for questions and discussion. And joining us to help moderate the discussion, we have Dr. Vida Boyer, who is the Associate Director of Northwell Neonatology and Medical Director of Neonatal Perinatal Medicine and Director of Neonatal Wound Service at Cohen Children's Medical Center in New York. And Dr. Vivek Narendran is the Medical Director of the NICU at the University of Cincinnati Medical Center and an expert in neonatal skin biology, including innate immunity of the skin. We'll wrap up the discussion by around 12:15 Eastern Time. So I'd like to thank our speakers and moderators in advance for sharing their expertise. And with that, I'll hand it over to Dr. Visscher to get started. And please unmute yourself, Marty.
Thank you to the organizers and to Noelle for putting this together and also for inviting me. It's an honor to be able to talk about this subject. So let's begin with the objectives, which are to talk about the structure and development of the skin barrier less than 24 weeks, some strategies to facilitate its maturation and take care of it, and then finally talk about pressure injury prevention and management. So if we look at go back to the time, actually these data are from 1975, it prompts us the fact that we're treating babies 22, 23 weeks prompts us to go back to that literature and re-educate ourselves on what we know. So what you're seeing here on the left is a light level microscope of the skin of a fetal skin about 20 weeks gestation. And then on the right, it's a surface scanning electron micrograph. This work was done by Karen Holbrook and her colleagues throughout the time. She spent about 25 years on this topic and has really provided fundamental information. So if you want more detail, go look at her work. But basically, looking at the light, first of all, looking at the scanning electron micrograph, you can see there are hair follicles at this point in time at 20 weeks. You can see on the skin surface some things that look like they're going to lift off. That's keratinized cells. And then you see over toward the left smoother areas, and that's identified as the periderm, which is partly covering the infant at this point. In the light microscope, you see that there are two types of periderm. There's dark periderm and light periderm. And then we see a little bit of keratinized cells on the surface. But again, it's very minor in terms of the total area of coverage. So then if we move on to a bit older, a 26-week infant where there's 6 more weeks of development, and also a few weeks older than the babies we're focused on today, we see there's, on the light microscope, there's a keratinized epidermis. There's no evidence of periderm at this point. There are 2 to 3 spinous layers and 5 to 6 layers of stratum corneum here. In the transmission electron microscope, you could see more details. So it gives you a sense of layers. Distinct layers of stratum corneum have formed. So in that period of time, there's a great deal of biology. And one of the things that is intriguing, especially because when we think about the infant being born at 22 to 23 weeks, we believe that the periderm regression, meaning when it starts to disappear, is actually very similar to cornification in adult skin. And so at this point in time, the cornified envelope has involucrin, small protein-rich protein, loricrin, transglutaminase, and they appear at various stages of periderm development. So it looks like this process is carefully orchestrated, and we're seeing infants just at that time. So the question is, what's going on when we have a 23-week infant born? Vernix hasn't started to cover the fetal surface, and vernix is the material that we see in the last trimester. It's from stem cells from the hair follicle and lipids from the sebaceous gland that eventually cover the whole skin surface, and in a healthy infant make the baby pretty difficult to hear from with a stethoscope. So the question is, what happens here? What would be happening in utero at 23 weeks, just before vernix is really prevalent? And what is the effect of the birth and the post-birth environment, because that's what you're looking at in taking care of these. One of the other things I wanted to mention, if you do take a cartoon view of the skin, and these are the top layers of full-term skin. So full terms would have maybe 15 layers of the stratum corneum. Then we have the epidermis, and this shows their dermis. Now it's an exaggeration. It shows the collagen, it shows the vasculature. But in a premature infant, they're just a few layers, if any, and we don't have the deep connections, and we don't have the collagen. So what happens as a result is the layers are just not held together. And that means when you put something on the skin and then remove it, it's very possible to get a break everywhere. So the stratum corneum can come off, the epidermis can come off and just leave the dermis. And sometimes you can even take the whole skin off. So what happens in these babies is much more dramatic, and we keep that in mind in terms of how we treat it. So this slide shows we want to talk about measurements and characteristics of the skin barrier. This one is a slide of a transepidermal water loss, which is the water movement through the skin. In full-term infants, this is as shown here, it's very low. It's in the range of 3 to 5 grams per grams per meter squared per hour. And this study was done in the late 70s at different relative ambient humidities. Notice, however, they only went up to 60% at that point in time. Ambient relative humidity is also relative to air temperature. So keep in mind that an infant would have the ambient temperature in an environment of an infant would be, in this case, it was about 34. Their skin temperature was about a degree higher. So again, transepidermal water loss is low in full terms, and it's inversely related to the humidity of the environment. So the more humid, the lower. In contrast, for premature infants, especially those under 24 weeks, we have extremely high values. So this would be in this very edge. In fact, this graph is a bit outdated because now we have data on 22 and 23 weeks, but it's extremely high, in the order of 70 or 80 grams per meter squared per hour. And that's almost like what you would get if you measured over a pan of water. So it's dramatically different. And even in a few weeks of just further gestation, it would drop more than in half. At 26 weeks, it would be around 30 to 35, and finally starts leveling off around 33. So we're dealing with a lot of water loss, hence we have to manage their fluids. So what's the role of the incubator? We want to talk about this because, as Noelle said, there's a range of humidities. Most of them are over 80%. And this, again, what is supposed to happen is normal respiratory water comes through the skin. But in the incubator, if you put a baby in an incubator, the purpose is to keep the humidity in. So the incubator humidity is effectively lowering the amount of water that's coming through the skin. So the measurement itself, the TWL measurement that you record, is dependent on the humidity of the environment. The higher the humidity, the lower the reading will be. And that's a concept to really keep in mind as we think about care. So another thing I want to introduce is a concept of skin surface hydration. because this is really the key in terms of managing the infant's skin. This is a study from 1995 by our colleague, the late Steve Hoth and his colleagues. In this study, he had 40 babies. There were some babies who were younger than 30 weeks. They were kept at 70 to 74%. There were babies 32 to 34 and then full term, and those babies were at 44 to 49%. What this graph shows is the measure of hydration. The hydration measurement is very easy to make. It's the equipment has a probe that's about the size of the top of a pen. And what we see here is that the older babies, older preterms and full terms, have very low skin surface hydration. But the babies under 30 weeks have higher, much higher, significantly higher. And there's a lot of variability. So you see big error bars. This is the change that happens over keeping the probe on for 12 seconds. So these are in two different humidities. So we still see the hydration. And now if you look at this other figure, this one is for only the babies who were under 27 weeks. I think we had the youngest was 25. So they're a little bit older than our babies. But what's so impressive is the dramatic change over time. So the high values you see on day one, between 350 and 600 on this instrument. But by day 5, these same babies have a much, much, much lower hydration, even though they're in 70 to 75% humidity. So we have a process going on where they rapidly form some more that rapidly undergoes cornification after birth. And this is much more rapid than it would be in utero. So being born is a trigger, and the changes in the conditions is a trigger for the infant to start forming, cornifying more of the skin barrier. So why is this? Why are we making a big deal of this? Well, because we use varying incubator levels. And what we know is that both relative humidity and gestation influence the surface hydration. So if the baby's in high humidity, that's going to keep the water inside, and therefore the skin surface will be wet. And so that's what you're dealing with, is how to take care of wet skin. Well, wet skin is more permeable. So if you put something on the surface of it, that's going to penetrate. In addition to the fact that there aren't very many layers to prevent penetration. The other thing is that there's a high coefficient of friction. So it's more, if you move across it, rub across it, it's going to cause more damage. It's also less adhesive. It's very hard to stick tape to wet skin. So there we have tapes, life-saving tapes and leads that don't stick. So this is a very difficult environment to have to deal with. And I say that because it is difficult, and we are also limited in the science of what we know in terms of how to tease out and how to influence this. So if I show the diagram, see, I call this picture dressing the premature infant, because we put leads, we put tubes or tape to protect their skin from NG tubes and ET tubes. We put lines in, we'll put an umbilical line in, and we're doing all these things, touching the skin surface. The baby is on some kind of a bedding, and that skin is wet, and the skin is fragile. So if you move the baby the wrong way or look at the baby, the skin could be damaged. So it's a very difficult situation. And that forms the basis, though. So what we're trying to do is help people think about what it is that's going on so you're not surprised. Over time, the baby's skin will dry out, will start to cornify. When that is something we're hoping to understand very soon. So moisture impacts the care. Everything, neck folds, knees, ankles, flexing, the baby moves. So everything, all the lines, probes, leads, tape, devices that we do, and managing moisture. What we try to do is create a drying stress. And how do we do that? So here's some examples of what we see with a 22-weeker day of life. You see what we call glistening skin. It looks shiny. It's because of the reflection in the camera. And so that means it's wet. And we see some injury here. They put the leads on the shoulder to try to stay away from the abdomen. And then another case on the right is a breakdown in the neck. The baby's necks are very short, and so it's very occluded and very wet inside that area. So the strategy we've come to understand is that we need to identify these moisture areas and we use a water vapor permeable dressing. It's a foam dressing called Mepilex Light. It has a very, very little adhesive, so it doesn't stay on very well. But we know from other projects that it moves moisture. So moisture will come from the skin surface, move from the skin surface into this dressing. And if you periodically change it and replace it, then it's a way of helping to manage the moisture. Here's an example of this same baby I showed you at the beginning, at the first slide on day 1, and now by day 6, the axilla and the abdomen, we see a different color also. And there's probably some bilirubin in this image, but the skin physically looks drier, and if you look at it in magnified, you'll see the texture of skin that's starting to cornify. So and this baby is still obviously in humidity. So that's the idea of it. Here's an example. I want to show something that we ran across and we learned what not to do. There's a dressing called Mepitel 1. I know it's used for a variety of things very effectively. It's a clear dressing with physical holes. When you put this dressing against the skin and the skin is wet, the moisture can come through the holes, but it doesn't come through the rest of the dressing. And so when we've used this in high humidity, we see wet looking, mushy looking skin for a lot longer than we hope to. So we recommend not using this dressing. We moved away from it and started using one that would pull moisture away into it and that could be replaced. The difference is too that you don't want to do anything that will trap water against the skin. And the problem is with the adhesives don't stick, we move to a more aggressive adhesive. And then when that comes off, it takes more of the skin with it. So it's a tough balance between finding something that holds and not damaging the skin. So what do we do if we get breakdown? These tend to come, as I said, from these forces adhesives, friction, chemicals, temperature, perhaps. And they can be superficial loss, just part of the stratum corneum. It can be all of the stratum corneum and part of the epidermis, or it can be the whole epidermis, part of the dermis, or even a completely full thickness wound. So depending upon the situation and the particular materials used. So to treat this, again, we don't want to add more water than we need to heal the wound. We cleanse it with normal saline or water, blot it dry, and again, cover it with Mepilex light dressing. We use a product called Mepitac tape, which is also a safe silicone and it's not particularly adherent, but it helps hold the dressing in place. So the idea of thinking about moisture and pulling moisture away is what you're trying to do. Another thing for securement, for example, when we need to put a probe on, the surface reflective covers have been a problem. So we put Mepitac tape against the adhesive and then just have a slit in it for the probe. So the probe is against the skin. And that works well without causing damage to the skin. So you'll see pictures of that. And then we remove it carefully with water or saline and sometimes use an adhesive remover. In terms of pressure injury or injury related to non-invasive ventilation, that's where we see most of the concern. These images show you a nasal bridge image where the mask was on the nasal bridge, as it is when they're wearing a mask. This baby's fitted with nasal prongs. You can see we've put a piece of thick tegaderm. It's against the prongs, so it doesn't have adhesive against the baby. This second injury is on this septum. You can see it lost surface. The surface is lost. Here's another. We see this one. You have to look a little bit to see the philtrum injury on the philtrum from the mask. And then this one has from the nose tip. So in terms of what do, we rotate, if we can, we rotate mask sizes as throughout the day so that we're not putting pressure in the same spot all of the time. We also rotate masks and nasal prongs. Babies don't like the nasal prongs. The other thing we do when we manage the NIV is to make sure we've adjusted the infant's position so the infant is not resting on the same spot all the time to avoid injury from that pressure there. We cut holes in a piece of thick Duraderm and place that against the skin to avoid the injury. And then sometimes if we get an injury, then we would apply Mepilex light to the nose bridge and under the mask to help redistribute the pressure because we're going to have to put that mask back on. And so finally, this is some research we're doing where this NIV is such an important thing to use, but we don't want to have injury. And so our biomedical engineers have been measuring pressure under the mask contact points. This is work that's in review and should be published soon. These interface pressures on the skin are much higher than expected, and they exceed the pressure that's hypothesized to cause the injury. Pressures were higher on the philtrum than they were on the nasal bridge and forehead. But what was really interesting was that the positioning of the device with respect to the infant, you can see these devices are attached with somewhat different configurations, and that has a significant effect on the pressure. So what we're trying to do now is create custom prongs so that we can avoid any injury and also determine exactly how we teach people to position the devices. So that's forthcoming. So as take-home messages, I wanted to have you think about the concept of the skin surface hydration. The skin surface is wet, and the environment and skin maturation itself influences how wet it is. We want to manage this hydration by creating a drying stress wherever possible, and then pay attention to the surface texture, color, and appearance, because over the days after birth, they will change and they will give you a clue as to how the skin maturation is going. If anyone has any questions on anything I've said, please feel free to contact me by email. And I will now turn it over to the next speaker, Carolyn.
Carolyn, you need to unmute.
Hey, sorry about that. Thanks again for inviting me to speak to you this morning about this topic. It is still morning here, and I'm going to talk to you about a couple of things. One is the use of medical adhesives in this population of babies and some of the options. I know Marty's already alluded to some of that, but I think it's important to explore it a little bit more in depth. I'm also going to describe this finding called an anatoderma of prematurity, which is possibly related to medical adhesives. And then I'm going to talk about skin disinfectants and the major controversies around the different disinfectants that we use. There we go. Okay, this is an array of the skin disinfectants that, the skin medical adhesives that are used in NICUs in today's nursery. And the one on the top, on the left, are the medical tapes that use acrylate adhesives. And there's a whole variety. Now, this pink tape actually is technically a zinc oxide, one of my least favorite tapes because it doesn't, it's not breathable. These devices called the neobars use something called a hydrocolloid adhesive. And this also shows you hydrocolloid being used as a base between the tape and the skin. This example here with a goalpost, which we know is actually not a NICU, also shows the hydrocolloid being used as a base. This is the polyurethane transparent adhesive dressing. Tegaderm is a common brand, but there's other ones too, Opsite and different types of Tegaderm. And they also have an acrylate type of adhesive. This is a hydrogel, which is typically used in EKG electrodes and also for temporal covers. And then this category here is relatively new, not really anymore, but it's new-ish. It's the silicone-based adhesives. But I just wanted to walk back in time and acknowledge the fact that we were one of the first groups to discover the damage that's caused by medical adhesives on neonatal skin. This study published in 1997 in the Journal of Pediatrics. We enrolled 30 infants. There were 10 that were less than a kilo, 10 that were a kilo to 1,500 grams, and then 10 that were bigger. And we applied a square of transport tape, hydrocolloid, it was polyadhesive at the time, and a hydrogel, and left that tape be on their back for about 24 hours. At 24 hours, we carefully removed it. And before we applied the adhesives, we did TEWL measurements as a measurement of skin barrier function. We also looked at the color and the visual inspection. After 24 hours, we waited 30 minutes. We measured the TEWL and the other measurements, and actually found that in all of the babies, even the bigger ones, we saw evidence of loss of barrier function with elevated TEW levels. But of course, it was more significant in the babies less than a kilo. And then we measured again in 24 hours and saw that there was fairly significant repair of the barrier. Of interest, though, we found, and we really wanted to study the hydrocolloid because we thought that would be more gentle. And actually, it was almost identical to the transport tape. So what we thought was going to be a benefit with hydrocolloids didn't really pan out. So these are some examples of epidermal stripping. Marty's really done a nice job of describing how really poorly attached the epidermis is to the dermis, particularly if preterm infant. This baby, we've nicely taken off the entire epidermis. This was a really severe medical adhesive skin injury, very deep down to dermis. This was more surface abrasion. And again, the skin on the face is particularly vulnerable. And we've seen pretty significant excoriations there. Now, I mentioned this category of silicone adhesives. And when they first came out, this was, like we always called it blue tape, but it's called Kind Removal by 3M. This is Gentac that was made by Medline. And this is the Mepitac that Marty was talking about from the company Molnlycke. Okay, so what was nice about the blue tape was that you could tear it. You didn't have to cut it with the scissors. But what we found at the time was that it adhered extremely well to hair and to skin, did not adhere well to plastic devices. However, just in the last year, 3M has reformulated their silicone adhesive. They've renamed it too. I have to say, I think companies that call everything the same thing is very confusing to health professionals. So they call this product Micropore S. Now, Micropore was always paper tape, but now Micropore S is the silicone tape. What I do like about it is that it comes in single-use rolls, so there's no contamination by it sitting, in the drawer for a while, and it also adheres better to devices. In fact, 3M has used this actually to make a securement device, which we've used for Foley catheters and for some other things, G-tubes and so on. So these silicone products are getting more robust in terms of their adherence capability. Now, this is a baby who's in high humidity. And when we have a baby in high humidity like this, it's really, really hard, as Marty acknowledged, to keep anything on them, particularly hydrogel electrodes just want to come off. So I give the nurses a roll of the silicone tape. But when I came back the next morning, the nurse had put a piece of the silicone tape on the skin and then attached the electrode to that. And guess what? It worked. So that was very interesting, I thought. But again, it's really, really hard in the high humidity environments. I also, one day, just as an experiment, put a piece of silicone tape on my hand and actually found that it adhered extremely well even after I did hand wash. So I think there are some advantages. I would very, very much like a company to make a silicone-based EKG electrode rather than the hydrogel, because I think that would actually be a real advantage. The other advantage to the silicone adhesives is that you can lift them up and replace them. You don't have to put a new piece down. Now, another product that works in high humidity is something called Tegaderm HP. As I mentioned, not all Tegaderms are the same, and this actually has a very different type of acrylate, and it's designed to hold more securely with moisture. And again, it's different than regular Tegaderm. It was designed to benefit patients who have, and we do see this in our long-term chronic babies, contact dermatitis reactions to regular Tegaderm and to Duoderm and to actually a lot of other adhesive products. But it also can adhere well in high humidity environments, patients who are diaphoretic, or if you really need the holding power. In fact, we're using the Tegaderm HP as our primary adhesive for securing PICC lines. This is another product. This is very interesting. This product came out, it was actually manufactured in Japan, and 3M was doing away with their cloth adhesive tape, and they started to market this, what they called multi-pore dry surgical tape. Well, I used it for a patient who was extremely slobbery and couldn't keep his ET tubes secure, and it worked really, really well. But then our nurses started to find, oh my gosh, this stuff is great. Can I have some of the white tape? So it actually has taken over in our NICU the traditional technique of using Duoderm and covering it with Tegaderm. People are using multi-pore dry surgical tape, and they're very creative with how they use it. The families like it. In fact, when they take home a baby with a NG or a gastrostomy tube, they want some of the white tape. So even some of the home health companies have started to carry it. Now, this is the dressing that Marty was talking about that is maybe not good. I don't know. I have not used it on large body surfaces. I've used it for wound care. But I think it actually works really well under pulse ox sensors and potentially under EKG electrodes. And again, it can be used as a dressing with or without ointments. I've used it with Metahoney. So another area of interest with medical adhesives are the barrier films. Marty mentioned these. These are plastic polymers that can be sprayed or wiped on skin. I'm not a fan of spraying. They're alcohol-free. They used to make products that were not, that were very irritating. Cavalon was the first product, Cavalon No Sting Skin Protectant. They held the patent for 15 years. But now other companies are able to make similar products. They're not all alike, but they are considered skin protectants. And this is just an array of some of the products on the market. The reason why I don't like the sprays is that I worry about inhalation, but these can be used as a base underneath tape. They've been shown to reduce the amount of injury. Next, we come to the category of adhesive removers. Now, we in the skincare guideline always advised against using them, but that was because we pretty much were talking about alcohol, organic-based solvents. They contain hydrocarbon derivatives or petroleum distillates. They say harmful or fatal if swallowed, so if they're absorbed through the skin, I would be worried about toxicity. And there is a case in the literature of a baby who developed severe blistering and later hemorrhage after exposure, and it was a pretty significant exposure to this product, Detachal. Then there's the oil-based solvents. Now we know mineral oil can help remove adhesives, and there are these citrus-based products. They have a fairly intense odor, but they leave an oily residue, and you really can't use them if you have to replace the adhesive. So the silicone-based removers are probably the safest medical adhesive remover. You know, it was interesting. I was traveling and I went down to Australia, and this nurse handed me this adhesive remover by Welland, and I was like, wow, this is really interesting. They call it a no sting wipe. And so then companies like Coloplast started to make it, and Convatec started to make them. But again, they're all a little different. But I want to propose a kind of interesting approach. One of our, again, new nurses said, you know what? That no sting, we used the Cavalon no sting or another product, actually removes adhesives. And so I think it's kind of an interesting approach. Rather than using these products as a base underneath adhesives, use it to remove adhesives. And then you've kind of got a 2-for-1 where you've got some protective coating. You've also got a way to remove adhesives without damage. I want to acknowledge Dr. Boyer. She's done some research using no sting on half of the body of premature infants and not on the other half. And she found that although TEWL was reduced, there was more skin dryness on the coated surfaces, recommends not using it to completely coat skin, but just use it under adhesives if you're using it for a protectant. And as I say, it can be used to remove adhesives. Now, I mentioned this term anectoderma of prematurity and wonder if it is, in fact, another form of medical adhesive-related skin injury. Look at the skin right here on this baby's side. It's hyperpigmented. There's a tear here. So it's very friable skin. And this was first written about in 1996 by Prezant, a pediatric dermatologist. These anectodermas, and you can get anectodermas for other causes, are atrophic patches resulting from thinning of the dermis. And in fact, in the cases that Prezant mentioned, they did biopsies and they showed an absence of dermal elastic tissue. And it is hyper or hypopigmented. It's found in extremely premature infants who have a lengthy stay in the NICU. It's absent at birth. Usually develops between 6 and 10 weeks of life. Usually the anterior trunk or limbs are involved. And the speculation is that the role of excessive traction with adhesive removal is causing subclinical dermal damage. So it is interesting. That was proposed by Visscher. But I want to show you a case that we saw in our NICU, a 23-weeker. This was really quite dramatic. It almost looks like, epidermal stripping here, which possibly it was, but to a hydrogel, which we did not find in our research caused any appreciable damage to the barrier of the skin. But this baby also has some damage shown here and on the arm. You can see this was several weeks later. This hyperpigmented skin tearing here, so it's very friable, and this kind of puckered appearance. And even later, months later, this baby does have quite significant abnormality of the skin, an anectoderma. In this paper, and I really think this was a very well done, it was published by the Swiss Society of Neonatology by Ruger. They described 4 different cases. They were very similar. If you look at the pictures to our baby's case, but they also include this illustration where they take their different cases and show where the damage was seen. And again, it's on the anterior portion of the skin. We've seen it on the arms as well. One of Marty mentioned, the neck folds. Any intertriginous area is particularly vulnerable. The skin does not seem to be as robustly developed in the neck folds, the axilla, or the groin, and so these parts are pretty vulnerable. It's interesting, the back doesn't seem to be as vulnerable. And in fact, with our baby, we ended up putting electrodes on the scapula, and they worked fine. So it was interesting. Last, I'm going to talk about skin disinfectants. This is an array of disinfectants. There's the chlorhexidine. This is an aqueous product that's available in the United States. It's very user-friendly. It comes in a bottle. You have to put it on a 2x2, but it is an aqueous chlorhexidine. This is Chloroprep 2% in 70% isopropyl alcohol. Another product is 3.15%. There is a 0.5% in 70% isopropyl alcohol. And if you're lucky enough to live in Canada, and actually in a number of the international countries, they make an aqueous single-use product of 2% chlorhexidine. There's also povidone iodine and isopropyl alcohol. Now, the efficacy of the products is really important, and it is of note that although CHG has been shown to reduce skin colonization, contaminated blood cultures, there's no evidence that it reduces bloodstream infections in neonates. Part of that is because in neonates, our central venous catheters have longer dwell times. They don't tend to get infected shortly after insertion. And we do know that the intraluminal route of infection is the most common source. In other words, it's through the lumen of the catheter, not around the surface of the catheter through the skin, that most babies get infected. So the care of IV tubing and how you access central lines is more important in preventing infection. This study from Ireland enrolled 304 infants. They were fairly low gestational ages, included 850 central lines. Interesting They found no difference between using 2% chlorhexidine in 70% isopropyl alcohol versus povidone iodine in terms of infection. But their infection rate was really low. And that's what we're seeing in most NICUs now. The infections are dropping off. But they did note that the babies exposed to povidone iodine had more thyroid dysfunction. 12 out of the 300 babies had elevated TSH levels. They did weekly screening in Ireland, and 8 were discharged on thyroxine. And this is systematic review also found that in 14 eligible studies, 12 to 33% of exposed premature infants had thyroid dysfunction. And the exposure is thought to be transient, but really the long-term effects are not. Interesting, from the Irish study, they recommended using chlorhexidine because they didn't see any problem with chlorhexidine. Well, they would be wrong in that we do see problems with chlorhexidine in terms of chemical burns. There's other adverse effects, including contact dermatitis. Healthcare professionals have that. There's even been anaphylaxis in adults. We know it's absorbed. You can get, in several studies, serum chlorhexidine levels, but we don't really know if there's a toxicity related to that. It's concerning. We don't know if chlorhexidine crosses the blood-brain barrier, and I'm hoping, unless any of you know otherwise, that we get that information. So the FDA in 2013, and to the best of my knowledge, it still holds, says use with care chlorhexidine isopropyl alcohol agents in premature infants less than 2 months of age. It doesn't say don't use it, it says use with care, but that these products may cause irritation or chemical burns. Well, chemical burns are a problem with any disinfectants. The way disinfectants work is they kill tissue and they kill microorganisms in that fashion. But this is some pictures of povidone iodine that was applied on periumbilical skin, removed with isopropyl alcohol, and the resulting skin burns. However, we see it definitely on a regular basis when we use 2% chlorhexidine and 70% isopropyl. And in fact, there's a growing number of case studies, case reports. But Beresford, which reports in the UK to their regulatory agency, published 44 cases of skin injury in neonates related to chlorhexidine. Most were less than 26 weeks, less than a kilo. 29 involved the product that had chlorhexidine isopropyl alcohol, and 11 were actually with aqueous chlorhexidine product. So what should we use? And there's been a number of papers that have said, and I agree with this, no robust evidence to recommend any topical antiseptic over another. You can't say one is really better in terms of preventing infection. Use with caution to avoid pooling, because this can cause significant burns. And was showing you a case of that. If you're using chlorhexidine gluconate, what is the optimal percentage? And because this is an international audience, would love to know more about other disinfectants. I read in one paper about 0.2% chlorhexidine acetate being used, octenadine. I'm wondering about ethanol, if anybody has studied that. The problem is that you can't really get a good handle on efficacy in terms of preventing infection because infection rates are low for other reasons now. The other thing I want to mention is that for the periumbilical skin, there are nurseries, and I think this is controversial, but some of you might be doing this, where they just prep the umbilical cord and they don't prep the surrounding skin. And I don't know, perhaps that is safe. I really don't have an opinion on that. And then last, we'll just show a couple of cases with skin breakdown, one related to medical adhesives, another to chemical burns. People are telling me they're seeing diaper dermatitis in this population, which I find quite surprising. And then other sources of breakdown. This was a medical adhesive skin injury that was probably from securement of the umbilical cord or the umbilical line, and we used medical grade honey. Dr. Boyer has published on this as well. And within 48 hours, we saw phenomenal healing The medical honey has anti-infective and also anti-inflammatory qualities due to high osmolality. And then this was a shocking and really horrible case, came to us with this huge blister on her back. This baby was likely lying in a pool of chlorhexidine with isopropyl alcohol. You can see how really serious this injury became. Initially, when it was moist like this, we used something called Mepitel AG. That's the Mepitel that is impregnated with silver, which has anti-infective qualities. Meta-honey in an injury like this can be quite uncomfortable, stingy even. But once you've got the slough that forms, meta-honey does a really nice job of lysing some of the slough, helping to debride this wound, and this eventually healed. So medical adhesives remain a challenge. We all know that. There is currently no research to recommend which disinfectant to use. When there is skin breakdown, there are case reports that suggest using medical grade honey and silver impregnated dressings could be helpful. And I want to leave you with this thought. Whenever you do see skin breakdown, even if you know what it's from, these babies, I think it's extremely helpful to get a skin culture, because this might be a clue if they become septic as to what organisms might have been introduced through that portal of entry. Well, that's all I have for now, and I think we can open to questions.
Great. Thank you very much, Carolyn. And I'd like to turn it over to our moderators, Vivek, Noel, and Vida, if you would like to start with the opening questions here. I think we have about 15 minutes. Noel suggested that we go for an hour and 15 minutes today. I'm really interested in your takes as experts in this area. What things did you find most interesting, and do you think that our audience should take away?
So first of all, I can start. Marty, Carolyn, thank you for such amazing and robust lectures. Lots of wonderful information, and the Q&A has been very active. There's a lot of conversation. So one theme that has come across, and maybe I'll start with that, is chlorhexidine application for decolonization in the NICU. So many NICUs are preoccupied with MRSA colonization, decolonization, and whether people use it for that. So I will start with my own. We do check our NICU for MRSA weekly, but we do not use chlorhexidine. So for us, we use betadine products the first 2 weeks. We don't use chlorhexidine for babies who are less than 1,500 grams or 4 weeks of age. And we do use it sometimes for the PICC lines in those who are older than 2 weeks. But what are your thoughts on using chlorhexidine for decolonization?
So, chlorhexidine, I really do worry about absorption and potential toxicity. I really do. And I think we still don't have a whole lot of data on that. I am completely, really worried about these daily wiping with that product for babies with central lines. Even for bigger babies, that's a big exposure. When you look at the past, what I call misadventures with hexachlorophene, and what happened when that was absorbed through the skin. And although chlorhexidine isn't the same, it's in the same category of agents. So I personally think it's justifiable to use povidone. I really do. We, in our NICU, have used the aqueous product. Somebody mentioned about wiping it off with the Sally wipes, with the normal saline wipes, which I think is really a great practice. And it was because of the guideline, I think, that we even have that product. But I think you're kind of deluding yourself if you think you're getting off all of the chlorhexidine. Chlorhexidine clumps onto the stratum corneum. And when they've looked at the absorption, they've noticed that it increases over time. In other words, you might think you're taking it off, but you're probably not taking it. So that's my thought.
Thank you. I completely agree. We do wipe it as well. And anybody else want to comment on that maybe? No?
So as a practical guideline, having heard the concerns, I would suggest, or I would recommend what we do is that we use for babies less than 28 weeks, we strictly use povidone iodine. And for babies greater than 28 weeks, we use chlorhexidine. And when you use chlorhexidine, use the lowest concentration possible. In the US, we don't have the aqueous form, so use the lowest form of the alcohol-based one.
What about hypochlorous acid, wash? So I use wash to clean the wounds. And you mentioned a little bit, sometimes in the very small babies, day 2 or 3, you can see almost a little bit like hyperkeratinization, that desquamation look sort of. I find that that's very helpful. Does anybody use wash for those purposes, for decolonization and for cleaning and for as an antiseptic?
We don't use it in our unit. I think the question is there enough information, and do we really understand what it might do to the surrounding skin? I mean, and when should it be used? So I think your experience is what we need to go on, Vita, because you're using it. I don't know if you have case studies or if you could put together what your experience is, it would be really helpful for everybody.
Yeah, I've had good experience. Again, those are case studies. This is, individual use, but I think that may be our next hopeful product that is actually decolonizer to see.
I think we need to find out. And if you have, the bandwidth, I think it would be really, really helpful. And coming from you, because you've got the vast experience. I just wanted to make one other comment to build on what Carolyn said about the CHG containing wipes that people are using to clean, I think they're using it to try to reduce infection in the hospitals, but the claims about their infection reduction have to do with a much different process of scrubbing the skin for 3 minutes. And the products that have this CHG in them also contain materials, they're actually surfactants that are damaging to the skin because they have to formulate it with something that will keep it stable. And so you put something, you wipe the skin, but then you leave the other stuff on the skin that can cause damage. And that I worry a lot about that, because then people go around and say, well, then we have to put emollient on it, and we're going around in a circle. So I'm hoping something can be done. I mean, I hope we get some data.
And when you look at the literature about these, this wiping with chlorhexidine, and it's been done in NICUs as well. In Toronto, they published quite. They don't get to zero. They don't get to zero. If I really thought the skin was the source of the bloodstream infection, but I don't think it is. Our NICU is into its 4th year with 0 infections. And we've never done the chlorhexidine. I mean, I was kind of put my feet to the fire to fight against it because it's part of the bundle. But guess what? If you really, really want to prevent infection, you worry about how you strain your lines, how you access your lines.
Right.
Yeah, you want to keep things clean, but to go to that extent and completely disrupt their normal skin microbiome formation, I mean, I just think it's really using a sledgehammer where you don't need to use it.
I think that microbiome issue is the other one. We may be not helping at all. We may be going in the wrong direction and not letting the microbiome develop as it needs to.
So the 2 questions that we sort of didn't talk about much, Marty, in your physiology, the one thing we didn't address was how the acid mantle develops, meaning how the skin pH changes with time. And the skin pH is very critical part of the innate immune function of the skin. So the preterms don't have that acid skin mantle. So the things that we do, all these skincare practices, I'm not sure what it does to the skin pH and the microbiome as well. We do so many things on the skin. I mean, we are now saying we'll apply all these different kinds of dressings from Mepitel 1 to Mepitel Light, different disinfectants, and we are trying to cover larger areas of the body to as prophylactically to prevent skin injury. So we might be, we might need to consider its effects on the skin microbiome.
Well, and that's a really important point, because we go around sort of preaching to try to get the skin pH to go down to be in the acid mantle range. And the literature on having an acid mantle pH and applying something to get the pH down is pretty strong around barrier repair. It's necessary in order to get the proteolysis of filaggrin to happen. It's necessary in order to get the commensal bacteria, the proper bacteria, to colonize the skin surface, because the bacteria interacts with the skin and does the physiology. So we in our experience, using something that will deliver an acid mantle is what we prefer, and we actually use them particularly in the diaper area, where we can lower the pH because the enzymes in the stool aren't as active at a pH of 5.5 or 5, and we think that helps with a number of things. But so having a layer whereby we put a lower pH in a treatment, or having something that in an adhesive that has a lower pH, would be something to consider.
There were a couple of questions about emollient use, which I think is interesting. Some people are asking about Sween cream. I have no experience with Sween cream. I do know Aquaphor's been the most studied in neonates. I mean, that is the one that is most studied. That's the one that pediatric dermatologists really think is beneficial for infants with atopic dermatitis. And in fact, it's interesting. I've been doing more reading about atopic dermatitis, and that the infants that go on to develop it do have a less robust skin barrier function, with more repeated measurements of TWL over time. And the pediatric dermatology community was really excited that maybe they could even prevent atopic dermatitis with the routine use of emollients. But it didn't really pan out in too large studies. Now they're still looking at other products with ceramides in them and so on. One of the questions, I think Medea Esser put it in, was about, is it harmful to use petrolatum-based products in oxygen environments, oxygen-rich environments? That is an old myth that has been debunked many times. You can use Vaseline in the nares of an adult who's on an oxygen cannula. I mean, this is a myth that has really kind of grown out of proportion and is not a concern.
One of the most compelling things I read was a study by Pranav Yani and his colleagues of they surveyed 840 NICUs globally on the skincare practices and the skin injury, and these are babies under 28 weeks. They found more diaper dermatitis and perianal injury in units that use petrolatum-based products. So the question is, what is going on, and why is that happening? And so it's unanswered. I think that's more work needs to be done to really understand what's going on.
Yeah, I mean, I don't know that that's a cause and effect. Some of the thoughts that I have about this diaper dermatitis issue, one has to do with those little teeny tiny preemie diapers that really cause an occluded environment on that skin that's got urine in it, right? And that alters the pH. And of course, now we have competing priorities where we don't want to disturb these babies for 6 hours. So they might not even get their diaper changed for 6 hours, and they're sitting in a urine-soaked diaper that's occluding the skin. And the other possible contributing factor, which I think is likely, is breast milk fortification and some of the products that are used, because I think that has really, and I don't know, Vita or Vivek, if you have similar observations, but we've certainly seen an uptick with the use of breast milk fortifiers.
And that's two things from Sween perspective versus Aquaphor or Vaseline. Anecdotally, again, but after many years, we actually have stopped using Vaseline or Aquaphor and have moved to Sween. The product is different. The base is on dimethicone, which is thinner than the Vaseline itself. And there is some thought that in these really tiny babies, the Vaseline may be very thick and the water vapors may not be able to escape as much, right? And maybe you have microscopic breaks in the skin, which will cause more bacterial translocation and entrance. We have had good success with Sween. We only use it as needed in the areas which are dry and flaky. We don't bathe the whole baby in it. And so we've been fine with that. And I do agree with you that one of the things that is very different is we have the small baby bundles now, small baby units, where we are hands off the babies often for 6 hours, and it's often mistaken for really not touching the diaper. And when we first did it in our unit, we actually had an increase in diaper dermatitis simply because people were not checking and leaving the baby alone. So this is a philosophy of minimizing the touch on care and how often, but definitely should be checked at least 3 hours. And one other point that I wonder myself, and I simply ponder about it, is not only do we have fortifiers, we have really moved on to using donor milk very early in these babies. And I do think that the microbiomes that we are able to establish, and therefore what goes through the rectal area from mom's own milk in the first few days is so paramount compared to donor milk that is older and doesn't have the same immunologic properties and microbiomes that may be protective towards the diaper dermatitis irritation.
So question about the emollients. Generally, emollients are used in extremely low birth weight babies to improve on their physical barrier, like the epidermal barrier, which is part of the innate immunity. So there are two kinds of, all these emollients are basically barrier creams. So the ones that we are talking about are mainly the emollients which are petrolatum based, like Vaseline, Aquaphor, Eucerin. The other thing that we have not discussed is not an emollient, the use of natural oils. Like, you can use coconut oil, sunflower oil, olive oil. These are all natural oil, which are used to coat the baby to improve their epidermal integrity or improve their barrier. So if you look at all these, like you guys have rightly said, we have moved away from using the petrolatum-based barrier creams for these very small babies. But there is increasing evidence now that these natural oils, which contain certain fatty acids which are inherently anti-inflammatory and antimicrobial, could be used. The one that is gaining a lot of attention is the coconut oil. So the coconut oil has an acid called lauric acid, which by itself has anti-inflammatory and antimicrobial activity. So there are units in the developing world that they routinely use coconut oil for these small babies. They just coat them from birth, from below the neck to the entire body, and leave it on for about a month. And there's a large study from Pakistan actually showing decreased late onset sepsis in these babies. They are about 250 babies. The point being that it's the corollary to this, the concern that why we don't use it here is we still want studies done in developed nations, as well as, like we were talking about, its effects on the microbiome development, because we're going to put this natural oil on top of the skin surface. And microbiome is also dependent on the care environment, in addition to what you were talking about, Vita. So we are still concerned about what it does to the acid mantle development, what it does to the microbiome development, how does it actually act at the cellular molecular level. So, but in less resource countries, I think it's reasonable to say, given its potential sort of safety profile, that if you want to use something as a covering or something to enhance the epidermal barrier, natural oils, particularly coconut oil, is the way to go. There are a lot of systematic reviews published on it, so it's worth looking at it.
We have just maybe a few minutes left. I want to address something that has come up in the chat and in the questions. Skin to skin, parents touch, surfaces, then when we have these little tiny babies. So in my own unit, we actually allow skin to skin after 72 hours if clinically feasible. I'm not sure what you do, but any thoughts on that? A lot of people have asked about that. And how it affects the baby's skin.
There's only one study that I'm aware of that looks at how it affects the skin. That was done several years ago with Susan Luddington Ho, and we really didn't get enough data to answer the question. The thing about skin to skin is if it reduces stress on mother and baby, then that's going to help everything because stress delays barrier repair, delays wound healing. And so that brings that whole question of, yeah, it seems like the right thing to do. I mean, people talk about, I mean, the benefits of it are well known. In terms of what does it do to the skin microbiome and the skin development, we don't know yet, but I think people would debate that for a while, but we don't see, I mean, people, Johan Ogren has done some studies. I think his was in 2012, maybe. So there's a little bit of data, but one has to consider all the factors.
In terms of a skin microbiome, it may be beneficial because there's actually an interaction between the two skin surfaces, between the parent and the baby. So there may be an exchange of this microbiome. So you're enhancing the skin commensals from the parent to the baby. So it may be a good thing. Nobody has specifically looked at it.
There's actually papers that came out, I think, about 5-6 months ago from Europe. I forget now by whom, that actually have looked at the colonization, decolonization of those that did skin to skin and those that did not. And those that did skin to skin early on had decolonized by 40% within the first 2 weeks. So it looks like data is coming out that not only is it less stressful, but it's also good for skin microbiome.
Yeah.
So this one, another question that everybody's asking is, what do you do for bathing these small babies, these periviable babies? What do you do in the first few days? When do you start using soaps or shampoos? Any recommendations?
There's just not much research to guide us in terms of bathing. I mean, all we have is people's kind of trial and error. Vida mentioned a product, hypochlorite, was it? Do you use that for bathing?
For bathing, for us?
Mm-hmm.
Yeah. So no, when you have like the desquamation, the hyperkeratosis, sometimes we will use a little bit of Bosch, which is stabilized hypochlorous acid. We will use it in a spot check, but not for bathing. I mean, I agree with you. There is not much data. We actually don't bathe our small babies. Sometimes later on in life, we will do it after 2 weeks of stability.
Yeah, we talked about it a little bit yesterday, but I know that there's concerns about chorioamnionitis, babies that are born, through a very infected material. And I think that you said that you weren't that concerned about it. I know that we've had an infant or two that have been born really in very difficult circumstances, born in a toilet or whatever, where we really did feel the need to cleanse them, at least somewhat. Usually just using sterile water, excuse me, and a cotton ball or something like that, just to cleanse, to try to reduce some of the debris. But I just think there just isn't much research. Some of you and people have asked me about this product called Fashe, Fashe. It's a wound cleansing product that's really quite popular. Again, we don't have any data, so I don't know. I can't recommend it. I can't say don't use. I mean, and in terms of the products that have some, synthetic detergents that have a more acidic profile, there might be some benefits. I don't know.
So the Fashe product, I believe, has a pH of 5 or 5.5. So that may be part of what it's doing. In terms of what the literature, the searching of the literature that we did, we found no strong evidence that bathing actually changes the colonization, either bathing with water or bathing with something else. And we know from other work that exposure to water actually removes natural moisturizing factor, which is part of the biology that starts to form after birth. And those natural, excuse me, natural moisturizing factor contributes to lowering the pH and so on. And bathing will remove that and make the skin drier. The other scary thing is the surfactants. Some of them are sensitizers, some of them are very harsh. And the data that's available in terms of studies is really, really limited. And from critical review, it's not very compelling. So we take a view that, removing contaminants, blotting, and so on is fine, but wait until 28 weeks and let the skin develop, because the babies are working really hard to form their barrier. So
Same here.
The other question is on bedding. What kind of mattress do you use? What do you lie these small peri-viable babies on? Is cotton fabric better or is it silk fabric? Any thoughts on that?
well, again, what we've seen is putting cotton, because cotton will move moisture, will wick moisture. It can't be rough, though. That's a problem. We've also seen a product that's called the Tortle. It's a thing that's device to keep the baby's head in position during the IVH protocol. And that Tortle uses medical grade cotton. We found when we have it on the baby's forehead and we take it off, the skin appears to be in much better condition than some other parts of the body. And so we're just curious about whether that's another strategy. There's also the idea of Gore-Tex. Gore-Tex as a material keeps things from coming in and it allows moisture to move away. We've not tried that, but it's tempting.
So the other thing, Marty, that you were talking about was you showed us how the temperature probe you try to minimize is placed on the baby. You're
Right.
trying to minimize the contact
Right.
of the adhesive on the baby's surface.
Right.
Do you have any suggestion for how do we do that for a UVC placement?
Well, I can share my screen again and show what we do with that. Hopefully people can see this, but basically we realize that we see a lot of abdominal wounding, and we think it's because of the antiseptic that's placed around the umbilicus in terms of inserting the line. That's part of what you're hearing, Carolyn, I think, where people aren't putting it there. They're only putting it on the cord. But in any case, so what we do is prepare the skin, we insert the catheter and suture it, and then have longer tails, and then wrap those around, and then put a clear tape. So you first put clear tape on both sides. You're making kind of a box. And then on the edges, you put a cotton tape so there won't be any rubbing. You can see the markings, but this line now does not have to be attached to the skin. It'll just sort of hang out there. It has enough substantivity to it because of the tape. This is something that was published in the UK by their National Healthcare Trust, whatever it is. It was published as a method, and when we use it, we avoid contacting the skin in the whole abdomen. So we minimize contact with adhesive. And again, that's if we can do that, every little bit helps. So that's described in the literature. I think we need to create some educational videos to show how it's done so people can see it, and rather than try to read the procedure.
Thanks, Marty. Another question is about zinc. People are asking if we add additional enteral zinc to prevent enteral diaper dermatitis. Let me say that we don't do it. It's not recommended. We routinely supplement zinc. It's there in their fortifiers plus in their parenteral nutrition. And we don't give additional enteral supplementation of zinc. But there are studies to say that it might facilitate growth in terms of length and weight and head circumference. But for diaper prevention, no. Diaper
Well,
dermatitis prevention.
yeah. I just had a master's student defend her thesis on the whole question of zinc and zinc oxide, and the data is pretty compelling in terms of the zinc having antimicrobial properties and having anti-inflammatory properties. But when you put zinc and zinc oxide in the diaper area with all the other confounders, it's a little bit difficult to sort it out. There are very few, if any, reports of a problem with too much zinc. There's zinc deficiency, but and we don't know what it might do to the microbiome. I mean, that's the big question that I have right now, is maybe it's helping. So Carolyn, I don't know what your experience with that is, but
Well, I definitely don't have experience with supplementing oral zinc in our babies. I mean, I'm old enough to remember I saw acrodermatitis enteropathica. I mean, we saw terrible zinc deficiencies, and it's pretty striking when they're there. I do think that zinc does help with wound healing. So if you have a baby who's got a significant injury or wounds, make sure that they're getting adequate zinc in their parenteral nutrition. But I think once they're getting enteral nutrition, I don't know that it would help. And in terms of the diaper area, I mean, I think a barrier is what you really need if you've got evidence of diaper dermatitis, at least the initial, fiery red contact dermatitis type. And so I think having that inclusive cover in the zinc, I don't know, does it make sense that Destin Maximum has twice the zinc oxide, twice the zinc of the generic product? So does that make it a stronger, sturdier barrier? I don't know. I do like the products that have some carboxymethylcellulose in them that can be a sturdier barrier, sort of a stomaadhesive kind of material that can create a better barrier.
Right.
It's not really a healing process. What you're doing is protecting from re-injury. And that's the principle, that's the concept.
All right, well, thanks so much to all of you. I think, there are a lot of really interesting questions raised about this relationship of skin integrity with the microbiome with risk of infection. So I think I'll just put in another plug to please look out for information for our next webinar. It's going to be at the same time slot on September 19th, and we'll focus on bacterial and fungal infections in this population. It's clear that there's a lot of experts, a lot of bedside experience in the audience. Thanks to everyone for attending and for the great questions and input in the Q&A and the great discussion. And I'd like to just again thank our speakers and our moderators for sharing your expertise. It's a challenging topic, but I think I personally learned a lot, and I hope the audience did as well. So thank you very much. All right, well, that will sign off. Thank you.
Thanks, everybody.
Thank
Take
you.
care, everybody.
Thanks, Carolyn. Thanks, Marty.